Imagine someone walks right up to your pharmacy counter.
Okay.
Their eye is bright red, they are in blinding pain, and they are suddenly vomiting.
Oh, wow. Yeah, that's intense.
Right. Your first instinct might be that they have some weird case of food poisoning or maybe like a really severe migraine.
Which makes sense on the surface.
Totally.
Yeah.
But what if I told you they actually have just a few hours to get to an emergency room, or they will lose their sight forever?
Yeah, that is a terrifying scenario.
It is. So welcome to this deep dive. Whether you are a medical student, a young professional entering the field, or just, a dedicated self-taught learner who really wants to sharpen your clinical acumen, you are in the exact right place.
Absolutely.
Because as educational content creators and medical experts, our mission today is to provide you with a really comprehensive summary, a full masterclass in differential diagnosis in a primary care setting.
And we are not going to omit anything. We are detailing this thoroughly using clear scientific language, but, keeping it simple and engaging.
Right, avoiding the unnecessary jargon where we can.
Exactly. And our foundational guide for navigating all these diagnostic muddy waters is Paul Rudder's really incredible textbook.
Ah, yes. Community Pharmacy, Symptoms, Diagnosis, and Treatment.
Specifically the third edition. It is just a goldmine for clinical practice. It focuses so heavily on how to distinguish the benign, everyday stuff from the truly dangerous.
Which is the real challenge, right? I mean, if you're a GP or you're working in a hospital...
You have tools.
Exactly. You have blood panels, MRI machines, full medical records. But if you're a community pharmacist, you don't have any of that.
You really don't. You might have 5 to 15 patients walking up to your counter every single day, presenting with raw, completely undifferentiated symptoms.
It's such a highly unique clinical environment. It is literally just you, the patient, and a conversation.
That's it. Your only tools are rigorous history-taking and, well, a very deep, fundamental understanding of pathophysiology.
Because your mission is to filter out those self-limiting conditions, the minor ailments you can safely treat over the counter.
Right, separate those from the sinister pathology that requires an immediate medical referral.
It's like being a medical detective, but you can only interview the suspect. You can't, dust for prints or anything.
That's a great way to put it.
So let's jump right into the most crowded waiting room in primary care, which is respiratory diseases.
Oh, definitely.
The textbook notes this accounts for 700 to 1,000 GP visits annually per doctor.
It's a massive caseload.
It really is.
Yeah.
And I always assumed this was just because we're constantly breathing in each other's airborne germs, like someone sneezes on the bus and boom, half the city has a cold.
Yeah, well, that is the common assumption. But the etiology, the actual mechanism of how the virus spreads, is quite different.
Wait, really?
Yeah.
Yeah.
So while rhinoviruses account for about 30 to 50% of these cases, the primary mode of transmission actually isn't droplet inhalation.
Okay, then what is it?
The primary route is direct contact.
So it's less about the sneeze and more about what the sneezer touched.
Precisely. We call them fomites. Yeah, inanimate objects that carry the infection. So a patient touches their runny nose, then touches a door handle or a keyboard or a subway pole.
Gross.
Right. You touch that same surface, and then you unconsciously touch your face, your nose, your mouth.
And I just physically transported the virus right to my own mucosa.
Exactly.
Okay, so once I've accidentally delivered this rhinovirus to my nose, what is actually happening on a cellular level to make me feel so terrible?
Well, the virus invades the mucosal lining and attaches to specific receptors. And this causes immediate damage to the ciliated cells.
Those are the tiny hair-like structures?
Right, the ones that sweep mucus away. So your immune system detects this cell damage and releases inflammatory mediators.
Like histamine.
Histamine and bradykinin, yeah.
Which is basically the body sounding the alarm.
Exactly. And these mediators dramatically increase capillary permeability. The blood vessels in your nasal passages literally become leaky.
Leaky vessels. That sounds awful.
It is. Fluid rushes into the surrounding tissues, resulting in edema. And you experience that swelling as severe nasal congestion.
Ah, okay. And all that excess fluid dripping down the back of your throat.
That's what causes the persistent cough and the sore throat.
Which explains why kids are essentially walking germ factories. The epidemiology in the text shows children get anywhere from, 5 to 12 colds a year.
Yeah, peaking around ages 4 to 8.
All adults average maybe 2 to 4. Why the huge gap?
You really have to look at it from an immunological perspective. The pediatric immune system is, it's a blank slate.
Oh, why?
It is actively building its library of viral encounters. Every infection is a new data point for them.
But adults already have that data.
Exactly. Adults have built that library, so they often fight off the rhinovirus before the severe symptoms even manifest.
But if I'm the clinician, just counting colds isn't the job. I need to know when a cough isn't just a cough.
Right, the red flags.
Yeah, like chronic obstructive pulmonary disease, COPD.
Mm.
That includes chronic bronchitis and emphysema, right?
It does. And over 1 million individuals have it, causing about 25,000 deaths annually.
So how do you actually distinguish a tough viral cough from something like COPD or, say, severe croup in kids?
Well, it comes down to the quality of the sound, of the chronicity. A viral cough is acute, peaking in a few days.
Okay.
But COPD presents as a chronic, progressive decline in lung function, usually with a long history of smoking and daily sputum production.
And with pediatric patients.
You listen for stridor.
Stridor, that's that harsh vibrating sound when they breathe in, right?
Yes. It's a high-pitched vibrating sound caused by turbulent airflow through a partially obstructed, really swollen upper airway.
So if a kid comes in with a cough and stridor,
That points to severe croup, and that requires an immediate medical referral for corticosteroids.
like oral dexamethasone.
A nebulized budesonide, yeah. The steroid rapidly suppresses the inflammation and reduces airway swelling. It can literally be life-saving.
Wow. Speaking of reducing swelling, I want to bounce a practical example off you regarding over-the-counter nasal decongestants.
Okay, let's hear it.
The sympathomimetics. To me, using these sprays feels exactly like taking out a payday loan with a terrible interest rate.
A payday loan. Unpack that analogy for me.
Think about it. Your nose is completely blocked. You buy this topical spray, you use it, and you get this immediate glorious rush of cash. Or, in this case, a perfectly clear, open airway.
Right, it works instantly.
It feels amazing in the short term.
Mm.
But a week later, the physiological debt collector comes knocking, and the cost is way higher than what you originally borrowed.
That is a phenomenal clinical analogy. I love that. You've just perfectly described a condition known as rhinitis medicamentosa.
Rhinitis medicamentosa. But why does it happen? Why does the body punish you for clearing your nose?
Well, it has to do with receptor fatigue and vascular dynamics.
Okay.
Topical sympathomimetics work by aggressively stimulating alpha-adrenergic receptors in the nasal blood vessels, forcing them to constrict and shrink.
So the swelling goes down.
Yes, but if you use them continuously for more than 5 to 7 days, the body downregulates those receptors.
Oh, I see.
They become fatigued and actually dependent on the external drug just to maintain normal tone.
So when you stop the spray,
The vessels lose their tone completely. They dilate massively, causing a rebound vascular engorgement.
which is often way worse than the initial cold congestion.
Exactly. So the patient naturally uses more spray to fix the new congestion, and the debt cycle just spins out of control.
So how do you safely break that cycle or treat allergic rhinitis properly in the first place?
We use a structured pharmacological protocol. For mild intermittent symptoms, a non-sedating antihistamine like loratadine is first line.
Because it just blocks the histamine receptors.
Right. But if they are dealing with moderate or persistent symptoms, then you escalate
To what?
to topical mast cell stabilizers like sodium chromoglykate eye drops or corticosteroid nasal sprays.
How do those work differently?
Instead of just blocking histamine after it's released, mast cell stabilizers prevent the mast cells from breaking open and releasing the inflammatory mediators in the first place.
That is so smart. Now, there's also a major red flag with those sympathomimetic decongestants that we really need to highlight, right?
Absolutely.
An interaction that could actually be fatal.
Yes, the interaction with monoamine oxidase inhibitors, or MAOIs, which are sometimes prescribed for depression.
Drugs like Manarix.
Exactly. MAOIs block the enzyme that breaks down neurotransmitters like adrenaline and noradrenaline.
And sympathomimetics basically mimic adrenaline.
They do. So if you combine them, you flood the system with adrenaline that the body physically cannot break down.
Which spikes the blood pressure.
It causes a sudden, massive hypertensive crisis. It can lead to a stroke or a heart attack.
That is terrifying.
Patients on MAOIs must avoid these decongestants entirely.
See, this perfectly illustrates why the history taking is so vital. And you know what's interesting? The mucosal lining that's getting wrecked by that rhinovirus. It doesn't just stop in the nose.
No, it doesn't.
It's a continuous interconnected network right up into the eyes and the ears. Which brings us to ophthalmology and optic triage.
Sensory systems are notoriously tricky because the tissues are just so delicate.
Right. A wrong differential diagnosis here can escalate into permanent sensory loss so fast.
Very fast.
Okay, so I'm looking at this list of red eye conditions in the textbook, and honestly, They all sound identical to me. If someone walks in with a bleeding, red, oozing eye, my instinct is to panic and send them to the ER. How do you actually break this down?
You have to isolate specific variables. You look at the type of discharge, the presence of pain, and visual acuity.
Okay, let's look at conjunctivitis first.
Sure. If it's bacterial conjunctivitis, you will typically see a mucopurulent discharge.
Which looks like what?
It's a sticky, thick, yellow-green crusting. It often literally glues the eyelids shut in the morning
Oh, why is it yellow and crusty?
because of the immune response. Your white blood cells, specifically neutrophils, rush to the eye to consume the bacteria.
Oh, I see.
They die in the process. And that accumulation of dead white blood cells and cellular debris is what we call pus. Interestingly, 65% of bacterial conjunctivitis cases resolve in 2 to 5 days without any treatment at all. Though, topical antibiotics do speed up recovery.
How does that compare to viral conjunctivitis? Do viruses not cause pus?
Generally, no. Viral infections trigger a different type of immune response, mostly involving lymphocytes.
So no thick, purulent debris.
Right. Viral conjunctivitis presents with a clear, watery discharge.
And allergic conjunctivitis.
That is driven by histamine. It's intensely itchy. It's usually bilateral, affecting both eyes simultaneously.
And I'm guessing it responds to the mast cell stabilizers we mentioned earlier.
Beautifully, yes. Or antihistamines.
Okay, then you have the visual conditions that look absolutely terrifying but are actually totally harmless, like the subconjunctival hemorrhage.
Oh, they look awful. A tiny blood vessel under the clear conjunctiva bursts, creating a sudden, bright red, solid patch on the white of the eye.
It looks like you're bleeding out of your eyeball.
It does. But crucially, there is absolutely no pain, no vision loss, and no discharge. It is quite literally just a bruise on the surface of the eye.
So it just resolves on its own?
Yep.
Okay, this brings me back to that scenario I mentioned at the very beginning of the deep dive.
The vomiting patient.
Yes. I was reading ahead in the sources, and that one red flag completely threw me. The textbook says vomiting can be a primary symptom of a severe eye emergency. Can you explain the anatomical mechanics behind that? Why would a cloudy cornea make someone throw up?
It sounds totally bizarre until you understand the fluid dynamics of the eye. The condition is acute closed-angle glaucoma.
Okay, break that down for us.
Inside the front part of the eye, the anterior chamber, there is a constant production and drainage of a clear fluid called aqueous humor.
It's what keeps the eye inflated, right?
Yeah.
It maintains structural pressure.
Exactly. But in acute closed-angle glaucoma, the anatomical angle where that fluid drains out suddenly becomes blocked. The eye continues to produce the fluid, but it has nowhere to go. So this causes a rapid, massive spike in intraocular pressure.
The eye is literally overpressurizing from the inside out.
Yes. And this extreme internal pressure physically stretches the delicate tissues of the eye. That causes agonizing, excruciating pain.
And the cloudy cornea.
The pressure forces fluid into the cornea, making it edematous or waterlogged. That's why it looks cloudy or milky, and it's why the patient sees halos around lights.
And I think the text mentioned the pupil becomes irregular and fixed too.
It does.
But the vomiting, how does the pressure cause that?
The pain and the rapid pressure change are so severe that they overstimulate the autonomic nervous system, specifically the vagus nerve.
Oh, which connects directly to the gut.
Right. It connects to the vomiting center in the brainstem. So if a patient presents with a red eye, a cloudy cornea, intense pain, and nausea or vomiting, that is a blinding emergency.
They need to go to the ER immediately.
They need immediate surgical or pharmacological decompression of the eye, yes.
Wow. Note taken. Okay, let's touch on dry eye syndrome briefly. It affects about 3% of older adults. But the text explains it's not just a lack of water.
Right. Dry eye, or keratoconjunctivitis sicca, is a failure of the tear film.
And that film has layers, right?
It's an elegant, 3-layered structure. The innermost layer is mucin, which acts like an anchor, sticking the tear to the surface of the eye.
Okay.
The middle is the aqueous layer, the actual watery part, and the outermost is a very thin lipid or oil layer.
Which slows down evaporation.
Precisely. So deficiency in any one of those layers causes that gritty, burning sensation.
So if you lack the lipid layer...
The tears evaporate into the air too quickly, and if you lack mucin, the tears just roll right off the eye without actually lubricating it.
Moving from the eye to the ear, the triage seems heavily dependent on the age of the patient.
Context is everything here. If a 4-year-old presents with a severe earache, but their temperature is normal and there is no fluid discharging from the ear,
What's the protocol?
it's highly likely to be a simple, self-limiting middle ear infection. Observation for a few days is usually the best course.
But if they have discharge,
If symptoms persist, or if you see discharge, they need a referral to rule out a ruptured eardrum.
makes sense. But what if it's a 45-year-old complaining of ear pain and some hearing loss?
In adults, it is frequently a mechanical obstruction, cerumen or earwax impaction.
And how do we treat that over the counter?
We use cerumenolytics, drops like olive oil or sodium bicarbonate. They physically soften and break down the wax plug so it can drain out.
Now, with the eye and the ear, even if the symptoms are confusing, you can at least physically see the cloudy cornea or the earwax.
True.
But how do you handle triage when the problem is entirely hidden? Let's talk about pelvic and abdominal pain. You have to rely purely on the art of asking precise, sometimes uncomfortable questions.
It requires immense professionalism, tact, and directness. Women's health triage is a prime example, specifically differentiating the causes of vaginal discharge.
The differential here is actually quite logical once you break it down, though.
It is. Vaginal thrush, or candidiasis, classically presents with an acute vulvovaginal itch and a white, thick, curd-like discharge.
And crucially, it has little to no odor, right?
Exactly. It is a simple fungal overgrowth, highly responsive to over-the-counter antifungals.
But the red flag is the scent.
Yes. If the discharge has a strong, pungent, fishy odor, you must consider bacterial vaginosis or a parasitic infection like trichomoniasis.
Why the fishy smell, just biochemically speaking?
Bacterial vaginosis involves an overgrowth of anaerobic bacteria. When these bacteria multiply, they produce volatile amines.
Ah, chemical compounds.
Yes, compounds that literally release that distinct fishy odor. Both of these conditions require a medical referral for prescription antibiotics or antiprotozoals.
And there are strict age-based triggers for referral, too, in this area, right?
Extremely important ones. Women under 16 or over 60 presenting with these symptoms must be referred automatically.
Why over 60?
You must rule out atrophic vaginitis, which is a thinning of the vaginal walls due to low estrogen, or more sinister pathology like a carcinoma.
Dysmenorrhea, or period pain, is another area where the history tells the whole story. The clinical distinction between primary and secondary dysmenorrhea is fascinating to me.
It's very distinct. Primary dysmenorrhea typically occurs in women under 30. The pain is a mild to moderate cramping that begins just hours before or concurrent with menstruation.
And this is purely chemical, right?
Yes. The underlying mechanism is an overproduction of prostaglandins in the lining of the uterus.
Which forces the uterine muscles to contract and cramp painfully.
Exactly. Which is why the treatment is so specific. We use nonsteroidal anti-inflammatory drugs, or NSAIDs.
Like ibuprofen or naproxen.
Right. They work by blocking the cyclooxygenase enzyme, essentially shutting down prostaglandin synthesis right at the source. A trial of 2 to 3 cycles is usually recommended.
But secondary dysmenorrhea is a completely different beast.
It really is. It usually occurs in women over 30. And the pain is a severe, debilitating cramping that begins days before menstruation even starts.
Which implies what?
That there is an underlying structural or inflammatory pelvic pathology, like endometriosis, fibroids, or pelvic inflammatory disease, that requires an immediate medical referral.
It's amazing how diagnosing the gut and the pelvis is basically an exercise in excluding structural damage.
It really is.
Which perfectly transitions to gastroenterology and irritable bowel syndrome, or IBS.
IBS is a functional bowel disorder typically presenting in patients under 45.
What are the classic signs?
It's characterized by an alternating pattern of constipation and diarrhea, significant abdominal bloating, and symptoms that are usually worse in the morning.
Okay, I have another analogy for you.
Oh, lay it on me.
Reading through the IBS criteria, it feels a lot like diagnosing a mysterious rattle in a car engine. Well, you only get to call it a functional quirk of the car after you've checked the transmission, inspected the brakes, and looked at the oil to definitively prove that nothing is actually structurally broken.
That is spot on. IBS is fundamentally a diagnosis of exclusion.
So you have to rule out the dangerous stuff first.
You cannot label it a functional quirk until you have rigorously interrogated the patient for red flags that might indicate inflammatory bowel disease, celiac disease, or colon cancer.
What are those engine-failing red flags for the gut?
Unexplained, rapid weight loss, any presence of blood in the stool. or an initial onset of symptoms in a patient over 50.
You must prove the structural engine isn't failing before you can safely manage the functional IBS quirk.
Precisely.
Speaking of managing GI quirks, the pharmacology of basic antacids is surprisingly clever.
It really is an elegant chemical balancing act. Antacids often combine magnesium and aluminum salts.
Why both?
The rationale is that magnesium salts act as an osmotic laxative, drawing water into the bowel and causing diarrhea as a side effect. Aluminum salts, on the other hand, slow down bowel motility, causing severe constipation.
So by putting them in the same liquid.
They perfectly cancel out each other's adverse effects in the lower GI tract, all while successfully neutralizing the excess acid in the stomach.
Elegant and simple.
Yeah.
Love that.
Yeah.
We can't leave the GI tract without talking about the entry point, though. The mouth. Specifically, oral aphthous ulcers.
Right. We categorize mouth ulcers primarily by size and grouping. Minor ulcers are less than 1 centimeter, and a patient might have up to 5 at a time. They heal quickly.
And major ulcers.
Major ulcers are large, can have irregular borders, take weeks to heal, and can cause significant scarring.
There's a third kind too, right?
Herpetiform ulcers, which are tiny pinpoint lesions that erupt in massive, painful clusters.
But there's a major red flag here, especially for older adults and smokers.
Yes. If you examine the mouth and see white patches on the mucosa that cannot be rubbed off, you must consider leukoplakia.
Which is dangerous.
It is a potentially premalignant lesion or an active carcinoma. That is an automatic, non-negotiable referral to a physician or dentist.
Okay, let's zoom out. We've covered the organs and the mucosa. Now we need to look at the structural scaffolding and the wiring of the body, the central nervous system and the musculoskeletal system.
This is an absolute minefield for triage.
Headaches seem like the perfect starting point because they are universally common, yet occasionally lethal.
True. The vast majority of patients present with tension headaches. That's a tight, band-like pain around the head that worsens with stress or dehydration.
I always confuse tension headaches with migraines. How do you tell them apart?
A migraine is quite distinct. It typically presents with a throbbing, pulsating pain, often unilateral.
Meaning isolated to one side of the head.
Exactly. It's usually accompanied by intense nausea, photophobia, sensitivity to light, and sometimes visual auras.
But what are the sinister headaches? The ones where the brain's wiring or vascular system is actually in danger?
The red flags here are incredibly specific. First, age. Any new severe headache in a patient under 12 or over 50 requires a referral.
And in a patient over 50, what are we worried about?
A severe headache accompanied by tenderness at the temples could be temporal arteritis.
What is that exactly?
It's a severe inflammation of the temporal blood vessels. If it's not treated rapidly with high-dose steroids, the inflammation can block blood flow to the optic nerve, causing sudden, irreversible blindness.
That is awful.
Another massive red flag is a headache that is worse in the morning or physically wakes a patient from sleep.
Why does the time of day matter for a headache?
Because of gravity. When you lie flat at night, cerebrospinal fluid dynamics change.
Okay.
If a patient has a space-occupying lesion like a brain tumor lying flat, increases the intracranial pressure further.
So the pressure builds up all night.
The pressure peaks in the morning, causing an agonizing headache that improves once they stand up, and gravity helps drain the fluid.
That is terrifyingly logical. What about insomnia? It's so common, but how do you know when it's an actual medical issue?
Duration is your primary filter here. If insomnia lasts more than 3 weeks, or if your history taking reveals it's linked to underlying clinical depression or severe anxiety, you must refer them to a GP.
So you are drawing a line between transient poor sleep hygiene,
Like drinking too much coffee.
right, and a psychiatric or chronic medical condition that requires managed care.
Exactly.
Let's talk about the physical scaffolding. The back. How do you differentiate simple back pain from sciatica?
Simple lower back pain is localized. It stays in the lumbar region.
And sciatica.
Sciatica implies compression of the sciatic nerve root. The pain radiates away from the lower back, shooting sharply down the buttock and the leg.
Okay, here is a question I've been meaning to ask. The textbook states that if a patient has lower back pain and suddenly experiences bowel or bladder incontinence, it is the ultimate siren warning.
It absolutely is.
Why? What does the bladder have to do with the back?
This brings us to a fascinating piece of neuroanatomy. The nerve roots that innervate and control your bowel and bladder exit the spinal cord at the very base of the spine in a bundle of nerves called the cauda equina.
Which translates to the horse's tail, right?
Yes. So if you lose control of those functions,
It means something is blocking those
it
nerves.
means there is a massive structural event, like a severely herniated disc or a tumor, that is physically crushing those lower nerves.
Oh my gosh.
This is called Cauda-Equina syndrome. It is an absolute surgical emergency. The pathophysiology is grim. If that pressure isn't surgically relieved immediately, the nerve death is permanent.
So the patient could suffer lifelong paralysis of the legs and permanent incontinence.
Yes.
Wow. Are there other musculoskeletal red flags to watch for?
Any numbness or tingling, which indicates nerve compromise, fever alongside back pain, which could indicate osteomyelitis, a bone
Like-
infection,
Anything else?
pain situated above the lumbar region in the upper back, which is highly suspicious for a malignancy, and finally, a failure of symptoms to improve after 2 weeks of diligent NSAID use.
Since we're talking about the nervous system and the skin it innervates, let's briefly hit the dermatological red flags. How do you distinguish between rashes?
Morphology and distribution. Let's take scabies. It presents as an intensely itchy rash that is significantly worse at night.
And where does it usually show up?
It often starts on the hands, wrists, or the webbing between the fingers.
Because it's an actual creature.
Right, unfortunately, yes. It's caused by a microscopic mite physically burrowing under the stratum corneum of the skin to lay eggs.
Shudder.
It is highly contagious and requires a topical scabicide like permethrin cream for the patient and everyone in their household.
Contrast that with shingles.
Shingles, or herpes zoster, isn't caught from a bug. It is a reactivation of the dormant chickenpox virus residing inside a specific nerve root.
So it's already in you.
Yes. When it reactivates, it travels down the nerve, causing a severe, lancing, burning pain, followed days later by a blistering rash.
And it has a very specific pattern, right?
Crucially, it only affects one dermatome, meaning it is strictly confined to one side of the body. It requires systemic antiviral therapy within 72 hours to prevent postherpetic neuralgia,
Which is what?
a debilitating long-term nerve pain.
Okay. This has been an incredibly intense, eye-opening journey through the body's warning systems. To wrap this up, as promised, let's do a rapid-fire clinical review exercise for you, the listener, to reinforce what we've unpacked today. Put your clinical detective hat on.
Let's see how well you can filter the noise.
Here is your case. A 32-year-old patient comes to your counter. They complain of a bright red patch on their eye that appeared suddenly this morning. They have absolutely no pain, their vision is perfectly clear, their pupil reflex is normal, and there's no sticky or watery discharge. Based on our deep dive today, what is the most likely diagnosis, and do you need to reassure them? I'll give you a second.
I guess.
Okay, if you said subconjunctival hemorrhage, you nailed it.
Perfect.
It is a completely benign, broken blood vessel requiring no referral, unlike the painful, cloudy cornea of acute closed-angle glaucoma.
That case perfectly encapsulates our core educational theme today. Medical mastery isn't just about memorizing drug names. It is fundamentally about mastering the algorithmic elimination of the dangerous, so you can safely and confidently treat the benign.
You are finding the hidden signal in a very noisy room.
And you are doing it largely just by talking to the patient, asking the right questions, and understanding the complex pathophysiology behind their simple words.
Which brings me to a final provocative thought to leave you with. We live in a rapidly changing era where artificial intelligence and at-home diagnostic tools are becoming ubiquitous.
Oh, totally.
You can scan a rash with a smartphone app, or you can check your heart rhythm with your watch.
The diagnostic landscape is shifting toward technology very quickly.
So as this technology increasingly takes over the basic data collection, will the skill of pure, unassisted human history-taking, the ability to look a patient in the eye, read their tone of voice, observe their body language, and understand their unspoken fears, will that become a lost art?
It's a great question.
Or will that deep human empathy become the one irreplaceable skill that forever separates true medical experts from the algorithms? Just something for you to mull over as you continue to sharpen your clinical acumen. Until next time, keep asking the hard questions and don't let the diagnostic murky waters scare you.